Hello everyone, welcome to another episode of Dental Digest with the Study Boards. I'm Dr. Trehan and today we will be continuing our journey through oral pathology series, and our focus is going to be on one of the classic odontogenic cysts, the residual cyst. Now it's a simple lesion in concept, but it tells us a very important story on what can happen when the pathology is not fully resolved. So here is a sequence that we are going to follow in today's video. First of all, we'll talk about origin, then pathogenesis, clinical features. Next, we will cover the radiographical features and histopathology, discuss some key complications and then their management, and finally we'll close the video with the differential diagnosis. So let's start with origin and etiology of residual cysts. Now first of all, remember that residual cysts, they belong to an inflammatory group of odontogenic cysts. So they develop in response to an infection or chronic irritation. Now how exactly do they form? Now it all begins with a periapical cyst that developed around a non-vital tooth, and when that tooth is extracted, if the entire cystic lining is not removed, a small portion of it can actually stay behind. These remaining cells are epithelial rests of Melisses or ERM, which are the remnants of Hertwig's epithelial root sheath. And under chronic inflammation or residual periapical infection, these epithelial cells actually begin to proliferate. Now over time, that proliferation leads to development of a new cystic cavity. That's what's called residual cyst. Now let's walk through the pathogenesis of residual cyst, which is very similar to that of periapical cyst. And again, it all starts with chronic inflammation from a lingering infection or a debris that was left behind after extraction. And that persistent inflammation activates T cells, which release cytokines. And these messengers stimulate the epithelial remnants, the rests of Melisses or ERM. And the ERM responds by proliferating, forming tiny early microcysts. And the fluid then accumulates inside these microcysts due to osmotic forces created by the tissue breakdown and inflammatory exudate. Now the cyst wall acts like a semi-permeable membrane, so the fluid keeps moving in and raising the internal pressure and driving progressive enlargement. So in summary, chronic inflammation really triggers T cells, cytokines stimulate epithelial remnants, that's ERM, then proliferating epithelium forms microcysts, fluid accumulation happens, which is driven by osmotic forces, leads to cystic growth. And the result is a fully developed residual cyst that can continue to grow silently unless identified and treated. Now let's go over some clinical features of the residual cyst, because these are the clues that will help you recognize it early, even when it doesn't cause much trouble at first. Now first thing is that it is frequently asymptomatic. Most residual cysts are found by accident on a routine radiograph, and patients usually are not feeling anything because these cysts grow very slowly and remain silent until they cause any significant pressure or infection. Now the painless swelling can be also causing very localized jaw expansion, because when these cysts do enlarge, you might notice a painless swelling or a slight bulge in the jaw. And that's simply due to the gradual expansion as the cyst presses on the surrounding bone. The third component of it is that the pain, discharge, or even infection could be noticed if the cyst has got secondarily infected. So the patient can present with pain, redness, or even purulent discharge, but only if it has been infected secondarily. A residual cyst forms only at the site of a previously extracted tooth, and usually because a bit of the cyst lining was left behind, as we have already talked about. Now let's look at the radiographical features of residual cyst. Now on an X-ray, it appears as a well-defined round or oval radiolucency. The borders are going to be usually clear and corticated, which makes it easy to spot and separate it from the surrounding bone. And you will most often find it in the edentulous area, right at the site of the previously extracted tooth. So that's going to be our biggest clue. And here is another important key point that you would like to look at. Unlike a periapical cyst, which is always attached to a non-vital tooth, a residual cyst is not going to be associated with any existing tooth. So if you see a tooth present there and a cyst, that's never ever going to be a residual cyst. And that distinction is what helps you tell the two apart radiographically. And in long-standing cases, you may actually notice some calcification happening inside of the cyst or a sclerotic border forming around it, and these changes can happen gradually because of chronic inflammation and the bone's natural attempt to heal. Now let's look into the histopathology of the residual cyst, and remember, it's basically the same as what you have already seen in radicular cyst or a periapical cyst. That is, the lining is made up of stratified squamous epithelium, which can vary in the thickness and often shows epithelial hyperplasia because of ongoing inflammation. Now inside of the cystic cavity or the lumen, you can find necrotic debris or inflammatory cells and those classic cholesterol clefts that sparkle really under the microscope, and that's important. Now the cyst wall is mostly fibrous connective tissue, heavily infiltrated by the chronic inflammatory cells like lymphocytes and plasma cells. They can ask you this question. And if there is an active infection going on, you may actually spot some neutrophils as well. Finally, a few special features worth noting are that you may even see hyalinized areas and sometimes Rushton bodies, and these are unique ribbon-like hyaline structures. Very important from your exam perspective. Now, they are not always present, but when they are, they strongly support the diagnosis of radicular type cyst, which includes residual cyst. Now let's talk about the complications of residual cyst. Now most of the times these cysts are asymptomatic, but problems really start when they either get infected or they're growing too large. And the first major complication is going to be infection. So if a residual cyst becomes secondarily infected, the patient can experience pain, swelling, and even abscess formation. Now this happens when bacteria enters a cystic cavity, usually because the cyst's natural barrier has broken down. And it's a serious situation that often requires immediate drainage or surgical intervention. The second complication is bone resorption, because as the cyst is enlarging, it is exerting pressure on the surrounding bone, which gradually causes its resorption. And over time, this can weaken the jawbone, making it more fragile and prone to structural compromises. And in more advanced cases, significant bone loss may require more extensive surgical management to restore both form and strength. Now let's discuss the treatment. Now the gold standard for residual cyst is enucleation, complete removal of the cyst and its lining to prevent recurrence. And if the cyst is large or it's in a challenging area, then marsupialization can be done, firstly to reduce its size before any definitive surgery is performed. And sometimes curettage is also performed to remove any remaining lining, and in selected cases, decompression can also be used to relieve pressure and shrink the cyst gradually. Now let's look at the differential diagnosis for residual cyst. And there are few lesions that can look very similar radiographically or clinically. So here is how we are going to tell them apart. First of all, let's discuss periapical cyst. It looks very similar, but it is always going to be associated with that of a non-vital tooth, while a residual cyst is always going to be associated with the edentulous area, which is exposed after extraction. Then we have to think about the dentigerous cyst, which surrounds the crown of an unerupted tooth, while a residual cyst has no such tooth association at all. Next is lateral periodontal cyst, which appears along the root surface of a vital tooth. Important, not an extraction site. And then finally, you think about odontogenic keratocysts, OKC, central giant cell granulomas, or even small ameloblastomas, which can occasionally mimic the radiolucency, but these tend to be more aggressive and show distinct radiographic patterns. So the key differences are tooth's vitality, location, and relationship to the surrounding teeth. Those are what help you confirm you're dealing with residual cyst. Now let's do a quick recap of key points of residual cysts. So they are inflammatory odontogenic cysts that form when a periapical cyst is not fully removed after extraction. It is found in edentulous areas, not associated or attached to any tooth. Then radiographically, it is a well-defined round radiolucency with clear borders. Histology, stratified squamous lining, chronic inflammation, cholesterol clefts, and then we discussed complications, infection, or bone resorption as well. Treatment-wise, enucleation is going to be the gold standard. Then we can also opt for marsupialization or curettage could be used if the cyst is large in size. Then we have to know differential diagnosis. So know that how you are going to differentiate it from periapical cysts, dentigerous cyst, lateral periodontal cyst, or any other aggressive lesions as well. Thank you for joining me in this episode of Dental Digest. Now, if you have learned something new, please like the video, subscribe, and share it with your friends who are preparing for the boards. Your feedback and questions in comments really mean a lot because they help us grow together. So stay curious, stay motivated, and I'll see you in the next one.